A very good evening to everyone. A warm welcome from Malaysia, and thank you for joining the webinar organized by Osstem Malaysia. And I was told that there is more than 400 participants, and it's overwhelmed the total number. For those who are not able to join us in this webinar, you can view it directly from the YouTube. Okay, so you can actually inform your friend who want to join us. They can actually view directly on the YouTube. So I'm Dr. Haken On. I will be chairing these sessions today. I am an oral maxillofacial surgeon in private practice in Malaysia. It is an honor for me to chair this webinar today. So without further ado, let me introduce our speaker. Our speaker is Dr. Ong Kok Kian, or better known as Dr. KK Ong. He is the founder of the KK Ong Dental Surgery in the beautiful island of Penang, Malaysia. He graduated with bachelor degree in the dental surgery from the University of Malaya. Dr. Ong has built up a career for over 2 decades with 15 years of experience in implant dentistry. As an educator as well as a practitioner, he also conducted lectures and hands-on workshop in the periodontal surgery and implant therapy in the University of Michigan School of Dentistry, Department of Periodontic and Oral Medicine. He is also currently a member of the International Association for Orthodontic and Implantology, IAOI. So this year, 2021, he is also appointed as the key opinion leader of Osstem Malaysia. So without further ado, we would like to invite Dr. KK Ong to present his lecture with the title, Tips for a Smooth Journey in Implant Dentistry. So Dr. KK Ong, the webinar is yours.
Good evening, everybody. Thank you, Dr. Ha, for your kind introduction. Thank you, Osstem Malaysia, for inviting me as a speaker for tonight's webinar. My name is Kok Kian. I am a private practitioner from Penang, Malaysia. I have been practicing as private practitioner since 1997. I have been practicing implant dentistry for more than 15 years. I like to perform interdisciplinary dentistry. I perform restoration. I do orthodontic treatment to improve facial profile, align teeth, and for better mastication. I also perform digital smile design in my clinic. Of course, I have special interest in implant dentistry. Normally, I have to perform hard tissue augmentation and soft tissue management, or soft tissue augmentation with implant placement. Here are a few examples of implant treatment I do in my clinic. Okay, today's topic is tips for a smooth journey in implant dentistry. To start the journey, even before we start our first implant placement, we should have some knowledge about implant dentistry. That means we need to do some reading about implant dentistry. We need to attend proper basic implant courses. We need to observe other experienced dentists performing implant treatment. So to start our journey, we need to do some reading about implant dentistry. We need to be knowledgeable about many aspects of implant dentistry, many of which we never have the chance to gain experience with in school. These are examples of few books that we can read. Second, we have to attend a proper basic course, preferably a few modules with hand-on. Osstem Malaysia organize basic implant courses every year. These courses will cover basic knowledge that every participant need to have before they start a simple implant placement. Of course, we should observe other experienced dentists performing implant treatment before we start to place our first implant. So we should start the first few implant cases with a simple implant placement. We should start our first few cases with simple implant placement in area of low aesthetic value. For example, in the area of premolar and molar. We should do a delay implant placement in the placement site with sufficient alveolar bone and soft tissue. We should have a proper clinical and radiographic examination. A CBCT scan is advisable. Of course, placement of dental implant with surgical guide is very helpful. So we should start our first case in the area of low aesthetic value. Example, the molar or premolar area. And those surgical sites should have enough bone buccally and lingually. We should have at least we should have at least 1.5 mm of bone on the buccal side and 1 mm of bone on the lingual side for the posterior implant, for the implant in the area of low aesthetic value. Whereas if you want to place implant on the more aesthetic area, which you shouldn't start as a first few case, should be on the anterior area, you should have more than 2 mm of bone labial on the labial side and 1 mm of bone, at least 1 mm bone on the lingual side. And the implant should be placed at least 1.5 mm from the adjacent teeth. And if let's say you have 2 implants, the minimum distance between 2 of them is 3 mm. And also, we should place the implant as shallow as possible, as deep as necessary. That means we have to think about the biological width for implant. So normally it's 3 to 4 mm apical to the mid-buccal gingival margin. That means if we plan our gum margin somewhere here, we should place our implant at least 3 to 4 mm below that margin, apical to that margin. Those are a few cases of delay implant placement in the area of low aesthetic value. That means we should start, as a beginner, we should start the implant placement on those areas of low aesthetic value. Those areas of low aesthetic value. That means in the area of molar or premolar. In this case, I place implant in the area of 3/6. So this is a photo taken before the treatment, and this is a photo after the treatment, and this is a photo 3 years after the crown had been fitted on the implant. This is the X-ray. And this is another example of delay implant placement in area of low aesthetic value. That means in the area of molar. So you should have enough soft tissue and enough hard tissue. Another example of delay implant placement in the area of low aesthetic value. And this time I'm placing a new implant next to another implant. Remember, they should have minimum at least 3 mm from the other implant. This is the CT scan to show that before and after 14 months after implant placement. Okay. After we have placed a few simple implants, we still have to continue our education in implant dentistry in order to have a smooth journey in our implant dentistry. We need to attending courses and seminar, and we should also read book in implant dentistry to update our knowledge. So these are again a few example of books that we should not miss. And Osstem Malaysia organize implant courses. Besides basic implant courses, they also have implant courses, advanced implant courses every year. Okay, the other very important tips to have a smooth journey in implant dentistry is taking clinical photograph. We should consider taking intraoral photograph before the implant surgery, immediately after the implant surgery, during the implant surgery if possible, or when we fit our definite prosthesis. That means when we fit the crown or abutment, when we fit our abutment and crown on the implant. And if possible, we should take a post-treatment. During our post-treatment review, we should take photograph as well. An example, in this case, the patient's tooth forceps cannot be saved. I'm going to do socket preservation, and I'm going to place implant a few months after socket preservation. So in order to learn better, in order to learn from our own experience, we should take photograph. So normally we should take a photograph before we start our treatment. And then we also should take a photograph after our treatment. For example, in this case, we take a photograph after I do a socket preservation with a high density PTFE and allograft. And then when the patient come back to review a few days after that, a few weeks after that, if possible, we take a photograph. Because photographing allows us to visualize and appreciate the chronological changes of the surgical site. That means you can know how your how the wound look like when you review the patient. So we can see how the soft tissue change, how the bone change with X-ray, but with photograph, we can see how the wound changes with time. So after 3 or 4 months, I place implant for this patient on the area of forceps. And we should take X-ray, we should take photo every time when patient come for review. For example, by taking photo, we know how the surgical site look like 8 months after crown fit, 18 months after crown fit. So as a professional, we are continually learning throughout our career. Courses, seminar, and other forms of continuing education are important educational vehicle. But I believe we learn the most from our own experience. Photographing surgery allows us to look back at our cases from incision design, osseous contouring, implant placement, suturing, and flat management. Photographs don't lie, and an honest self-assessment helps us to improve the quality of care we provide to our patient. So photographing allows us to visualize and appreciate the chronological changes of the surgical site. And the other very important tips to have a smooth journey in implant dentistry is that we should review our patient, and if possible, we should do a proper radiographic examination. We should radiographic recommendation protocol for implant surgery as below. Before we start our implant surgery, we should do a CBCT. That will help us to create our own digital surgical guide as well. And we should take at least a OPG immediately after the implant surgery. And we should take a periapical radiography when we deliver our definite prosthesis. And also to check our superstructure thickness we should check the fitting of the superstructure. So taking X-ray allows us to visualize and appreciate the chronological change of bone around the surgical site as well. So far, I mentioned that we need to do some reading about implant dentistry, attend a proper basic implant courses, and observe other experienced dentists perform implant treatment before we start our first implant placement. After performing a few simple implant placement, we need to have continued education in implant dentistry to update our implant knowledge. We need to take photographs, do a proper radiographic examination, and review our implantation yearly so that we can visualize and appreciate the chronological change of the surgical site. After we can start implant placement in the anterior area and implant site with bone defect only after completing few simple implant cases. In other words, we should try to start our implant career with a simple implant placement in the area of low aesthetic value before we start doing or before we start placing implant in anterior area or start placing implant on implant site with bone defect. There are a few types of bone defect. So we can start after completing few simple implant cases, we can start placement of dental implant in implant site with bone defect. We always start with immediate implant placement for type 1 extraction socket in area of low aesthetic value. That means you don't jump and place an implant in the anterior, especially immediate. You should, if you want to do immediate implant, you should do in area of low aesthetic value when there is adequate bone mass at the apical root side of the extraction socket to ensure the stability of the fixture. So these are examples of immediate implant placement. In this case, I do immediate placement on 1-4. So this is a picture, or this is an X-ray to show you 28 months after the crown fit on the implant. This is another example of immediate implant placement on the class 1 socket. This is an immediate implant on the tooth of 1-5, and this CBCT showed 21 months after the implant placement. So this is the immediate placement on the tooth 1-5 and a review 6 months after the crown fit and 21 months after the crown fit. So if we want to do immediate implant as a beginner, we should understand the pros and cons of immediate versus delay implant placement. And we should learn how to flap or when to perform incisionless treatment. And we have to be familiar with minimal invasive tooth removal technique and instrumentation. After that, we should have a solid understanding of the current literature and indication for grafting, and so and so. Okay, when we do immediate implant placement, ideally we should be able to do a dual zone therapy. We should understand dual zone therapeutic concept. That means we can achieve a predictable aesthetic success using a method that limited the amount of bulk contour change of the extraction site ridge and potentially enhance the thickness of the peri-implant soft tissue corona to the implant abutment interface. This approach involves atraumatic tooth removal without flap elevation and placing a bone graft up to the gingival margin into the residual gap around an immediate fresh socket on the anterior implant. So this is the case of immediate implant with using dual zone therapeutic concept. And this is a review after 4 years. But when there is inadequate bone mass apical to the root in the extraction socket for the stability of fixture, socket preservation should be done. We should not place immediate implant when there's no primary stability can be achieved. We should do delay implant placement then. So this is an example of when you don't have apical bone below the extraction socket, then you should consider graft first, then do implant a few months later. This is a photograph before treatment, post treatment. And this is a photograph to show you that we take out the tooth, we do a socket preservation, and we only place implant after 5 or 6 months later. Okay, we should start our implant with a few simple implant placement. Then we go to a anterior area and we go to the implant site with some bone defect. Start with a class 1 bone defect. Then after we have experience of placing implant in those areas with class 1, type 1 bone defect, we can go for the type 2. Type 2 means horizontal bone defect. For the type 2 horizontal bone defect, we can place implant with bone expansion. We can do guided bone degeneration, or we can do both bone expansion or bone splitting and guided bone degeneration to build out the ridge before we place implant. So the advantage of using bone splitting is that our implant will have direct contact with autogenous bone so that our implant can osteointegrate faster. So these are the indications for bone expansion with splitting. So those are a few examples of bone expansion. The patient start with some slightly horizontal deficient, and I do bone splitting and I place implant. This is how it look like after implant placement. Another example of bone expansion with crestal splitting, that means with bone splitting. The patient start with horizontal bone defect and I place implant with bone splitting. Another example of bone expansion with bone splitting. Here also the same thing. The patient have horizontal bone defect. So we place implant with horizontal bone augmentation by using bone split. No, sorry, with bone splitting. Okay, for the class type 2 socket, we can do guided bone degeneration as well. So in this case, you look at the area of 4-7, there's horizontal bone defect. So we place implant with some guided bone degeneration. That means we build the bone on the bulkar side of this implant, of the implant site. Another example of GBR, guided bone degeneration on the implant site with horizontal bone defect. So we do horizontal bone augmentation with implant placement. And that's how it looks after the placement of implant. And this is 18 months after the crown fitted on the implant. This is the occlusal view of the same patient. This is another example. When the patient's bone is deficient horizontally, we should do some guided bone degeneration to augmentate the bone before we do implant placement. This is 10 months after the crown have been fitted on the implant. Okay. After trying a simple implant placement, after trying placement implant on the anterior area, after trying implant on the simple class 1 extraction socket, after doing implant in the area with horizontal bone defect, then if you want to, then only you slowly go for a bigger horizontal bone defect. If a bigger horizontal bone defect, usually I will do bone expansion with bone splitting together with guided bone degeneration. So those are a few cases where I perform guided bone degeneration as well as bone splitting to build up, to augment, to expand the bone and to build out the bone horizontally before we place implant. Another example of GBR and bone splitting. This was 5 months after I fitted the crown on the implant. And this is a CT scan before the treatment and the CT scan after the 5.5 months after I fitted the superstructure on the implant. Another example of bone splitting and GBR on a horizontal deficient implant site. This CBCT was taken 5 months after I fixed the superstructure on this implant. Okay, when the patient do not have enough vertical bone height, we can do vertical bone augmentation. Usually, for a vertical bone augmentation, sinus graft is a treatment of choice. In this case, the patient do not have enough bone vertically. So in this case, I take out the 2.7, I do some GBR, and I wait for a few months, then a few months later, I place implant with sinus graft. That means I put some bone above the implant, underneath the sinus membrane. So this is a clinical photo of the patient before the treatment, and this is, we take out 2.7 and we do socket preservation, and we do GBR on the area of 2.6. And this is how it looked like after I loaded the implant with splintered crown. This is another example of horizontal bone augmentation. I'm sorry, this is another example of vertical bone augmentation, where I do a sinus graft. I place a graft underneath the sinus membrane in order to have enough bone height for implant placement. And this is a picture to show you before the treatment. Immediately after implant placement with sinus graft, and this is when I fitted the superstructure, the crown, splintered crown on the implant, and this is 15 months after the crown had been fitted on the implant. So this is occlusal view of the patient. And another example of implant placement with sinus graft. This case, I do a lateral window. That means I do a sinus graft by opening a window from the lateral wall. So by doing sinus graft, we can gain vertical height on the bone so that we can place an implant on the implant site. Those are the pictures to compare before the treatment and 2.5 years after I fitted the crown on the implant. Okay, there's another type of bone defect which is a bit difficult and then should not be tried by beginner. But anyway, after you have practicing for a few years, then and then you have do all the simple bone augmentation, then you can try to augmentate on the compound bone defect. And to augmentate this type of vertical and horizontal bone defect, you have to use a customized form of membrane, customized form of non-resorbable membrane, because it can provide initially contour stability of the augmented region. So this is an example of vertical and horizontal bone augmentation. This is before and this is after bone augmentation. Another example of vertical and horizontal bone augmentation. This case involves sinus graft as well. So this is vertical bone augmentation and sinus lift on the implant on 2.5 and 2.6. So this is before the treatment. This is after I augmented the bone. And this is when I place implant on the area of 1.5 and 1.6. This is after I fit the superstructure on the implant of 1.5 and 1.6. Again, this is a picture of review 30 months after the crown fitting on the implant. This is a lateral view of the same patient. This is a picture of, this is the X-ray of the patient. So, tips for a smooth journey in implant dentistry. We should learn and progress slowly to excel in implant dentistry. So we should be able to create the hard tissue, the rich site, which is ideal for implant placement to get a long-term stability of implant. We should create or maximize soft tissue around the implant to get a long-term stability with minimum gum recession. C, we should know the rules of placement for implant. That means we should know how deep should we place the implant, how far the implant should be placed from the labial bone, from the labial margin, and how far should we place the implant from the adjacent teeth and from another implant. And it's very important, so also we should know how to carry out proper implant maintenance. We treat our patient not only up to when we deliver the crown on the implant, we have to review our patient annually. And we also must be able to manage intraoperative and post-operative complication of implant placement as well as complication after doling of implant. And a very important point to have a smooth journey in implant dentistry is that we have to establish and maintain a professional and mutually satisfying relationship with our patient. And as you know, most dental implant treatment require a few visits. And we should try to provide a beautiful smile with fixed provisional prosthesis to our patient after every visit during implant treatment. There are various types of fixed provisional prosthesis during implant treatment. So I'm not going to go through everyone, but I just show you some example of how we can let patients walk out of our clinic after every dental visit during implant treatment. For example, this tooth 1.4 cannot be safe. We have to take it out when we place an immediate implant on it. But unfortunately, we cannot get a primary stability, or the patient dare not to comply with. That means the patient said that he cannot control that he don't bite that area. That means after implant placement, if we cannot do an immediate provisional on the implant itself, we should consider provide other type of provisional prosthesis. That means in this case, we cannot put the crown on the implant itself, we can use adjacent tooth. In this case, I do a resin bonded, fiber reinforced resin bonded composite bridge as a first provisional prosthesis for the patient. And the second provisional prosthesis with temporary abutment and crown will be done when the implant very well osteointegrated. We normally do why we have to do the second provisional prosthesis with temporary abutment and crown, because we want to get a proper contour for the soft tissue. We want to get a proper emergent profile for the gum around the implant. So this is another example. After extraction of this tooth, we use the tooth next to it to hold a resin bonded composite bridge on the implant side, so the patient can walk out with a temporary, so the patient can walk out with a tooth in the mouth. Another way is by using the Maryland bridge as a first provisional and using temporary abutment and crown as second provisional prosthesis. And there's many other way of provide temporary prosthesis. There's many other way of provided fixed provisional prosthesis to our patient. I'm not going to go through every one of them. So we should try to provide our patient with fixed provisional every time after their dental treatment, so that they can walk out with a tooth. So all the cases was carried out on a fee-paying patient in my dental clinic within the normal treatment time frame. There is no use of Photoshop other than crop, rotate, fix, and exposure adjustment. These cases are all my own. All the implant cases shared during this webinar are Osstem implant cases. With that, before we end our webinar today, or before we go to the question session, we are going to share a short video on placement of Osstem implant with digital surgical guide.
So thank you, Dr. KK Ong, for a very swift and smooth journey in the implant dentistry. So we are going to take a few questions. Ian, can you type up the questions? So how do you convince patients to undergo implant treatment? Dr. KK Ong? So how do you normally convince your patients, or patients just hear your name and then they will come to you for implant surgery?
Okay, the first thing is that you have to tell the patient it is important to have a tooth there to help them to eat, and sometimes they need to have a tooth there in order to be to look better. And of course, the most important is that you must show them some photo that you have taken for other patient and show them what is the difference before they have implant and what is the difference after they have an implant. That means you have to tell the patient the importance of having implant on the area.
Very good point. So if you are someone who are just starting and you do not have your own clinical pictures, so what do you do?
Or what do I do?
So you mean you can just take out from the internet and then show it to patients?
That's not the way actually. That's why
Yeah.
I suggest that you have to do some reading about implant dentistry. You have to attend a proper basic course, and then you have to see some experienced dentists perform it. Then the first few patients, if possible, you try to get your own relative to be your patient, and then you take picture of them and all that. Next time you can show to whatever your potential patient.
Yeah, a very good point. I think that I would like to bring out one point also, the various type of treatment that we use to replace missing teeth. So when we were in dental school, the first thing we tell patients, the way to replace missing teeth first is denture, then is bridge, either conventional bridge or a cantilever or other Maryland bridge. But now what we should tell patients, the first thing is that the best way to replace a missing teeth is actually dental implant. So you talk about dental implant first before you actually tell them there are other alternative to replacing missing implant.
Yes.
So any more question, Ian? What is the relationship between CBCT and implant dentistry? How vital is it?
Okay. To place an implant in a correct three-dimensional position, you have to know how much bone is available there. You cannot take a two-dimensional X-ray or whatever and tell patient that you have so much bone on the bulker, you have so much bone on the lingual. So it's important to be able to see how much bone that on the implant side that you can use for implant placement. And you must remember there's a lot of vital, you have to be careful of IV nerve, and you have to be careful of sinus, floor, and all those. So CBCT allow you to have a three-dimensional view of all those three-dimensional view of all those features.
Yeah, I think it will come to a point that guided surgery will be the standard of care for implant placement. So you must either a static guided or a dynamic guided implant surgery, and to do that you must have a CBCT. If your patient is a good patient with good bone and not in the vital structure, mainly the nerve and the sinus, then mostly a 2D will be a good enough and you have good experience. So, and I will come to a point that if without a CBCT and if you do an implant surgery, if there is some complications, then we might not be able to defend ourselves.
Yeah, for beginner, it's very important to have CBCT, because with CBCT, you can construct a very accurate digital surgical guide.
Yeah. So any more question, Ian? What would be your preference of bone graft in socket preservations, allograft or xenograft? Would Dr. Ong by mixing it with autograft as well?
My preference is usually allograft. because xenograft take too long to turn to our to be, I mean, to turn to a real bone, and then to do a to take a to use autograft, we have to have a donor site. Many patients would not allow you to do will not allow you to take another piece of bone from other side.
Okay. So your preference is still an allograft, so that you do not need a donor site, which increase the morbidity of dental implant surgery.
Yes, correct.
Have you tried any other method of harvesting autogenous bones from the implant site, like bone collector, bone scraper?
Yeah, I tried before.
Yeah. So do you think it will help in the total management of patient?
Yes. Okay. For example, if you do an implant on the area of 3/6, I mean, if you do an immediate placement on the area of 3/6, and then you know the area on the retromolar area, you have enough bone, then I don't mind open and collect a bit of bone. But if let's say implant is on the other side, and then you're going to collect on that side, sometimes patients don't really want it.
How about slow speed implant drilling without water irrigations? Then you can collect the bone that is actually come out together on the fluid of the implant drill.
That's a good idea. I tried before.
Yeah. So any more question, Ian? Is it okay to leave the membrane exposed during GBR?
Oh, ideally, we should not leave the membrane exposed during GBR unless you are using DPTFE membrane for class 2 socket preservation. That means you purposely leave the membrane. You still remember the photo I shared? I mean, let me show you.
Yeah, you go back. Yes. Go back to your slide. Ian, can you show Dr. Ong's slide where the PDFE is exposed for socket preservation? I think it was a good case. Very neatly done.
I show you the socket preservation. Let me show you. So in this case, actually, the patient do not have bone on the bulker side as well. So for this sort of class 2 socket, I prefer to use socket preservation with high density PTFE. And in this case, I use allograft. I use allograft so that I don't need to use autogenous graft. That means I don't need to take bone from other area.
Yes, understand.
So you have a look. This is a picture after a few weeks, and this is a picture 6 weeks after I removed the PTFE. And this is after 3 months, and I take a CBCT. You can see the allograft, not to say the bone is not mature yet, but it's good enough for us to place implant with primary stability.
Yes, very good.
So I only leave the membrane exposed in this sort of case. But if you really want to do a proper GBR, primary wound closure is very important so that we don't have membrane exposed during GBR.
Good. On the same point, how long do you normally leave your membrane on?
For this DPTFA, you have to take it out within 6 weeks. Usually, I leave it 4 to 6 weeks.
Good, 4 to 6 weeks.
Because sometimes this PTFE, the edge of it like to evert out, then it's not good anymore.
Yes. So I think whether you can expose or not to expose depends on the type of membrane that you use. Yes, if it is resolvable one, normally you want to have a good primary closure. If it is a non-resolvable of a PDFE, you can allow, and actually sometimes you want it to be exposed so that you can have a good thick keratinized tissue when you place your implant.
It enables maintenance of the soft tissue architecture.
Yes, correct.
Because we don't need to forcefully coronally advance the fluid to close the wound.
Correct.
I don't mention all this because this is not related to today's topic. It's too complicated.
Yes. Ian?
Would you perform
Under what conditions do you perform a two-step surgery, Dr. Ong?
For all the beginner, I advise you to start all your cases with two-step surgery. That means if the implant site is not ideal, we should build out the bone and the soft tissue before you do implant placement. But once you have enough experience and you think the bone augmentation is quite minor, you can do it simultaneously with implant placement.
Yeah, I think for beginner, a heel site with good bone and soft tissue is the low aesthetic demand area will be the good choice.
Correct.
And by definitions, you follow the ITI protocol. Immediate implant is for the SAC the classifications. Immediate implant is an advanced procedures. So you shouldn't attempt immediate implant in your first few implant placement.
Yeah, correct. The first few implant cases should always in the area of low aesthetic value with sufficient soft tissue and hard tissue.
Ian, would you prefer tissue level implant for posterior?
Actually, this is up to individual preference. If you think you can get a very good emergent profile with a tissue level implant, then you can try tissue level implant. But for me, usually I try to submerge the implant slightly below the gum so that I can get a nice emergent profile.
Yes. So I think in Malaysia, so most of us we use bone level implant. So
Correct.
the very famous tissue level implant is carried by the Straumann ITI. And if you see in the literature for the past 50 years, we are all talking about hard tissue osseointegrations. So now from now on, so most of them, they will be talking about muco-integrations. So they are already system that actually put in a tissue bone level implant and then immediately put in a abutment that is a tissue level. So converting a bone level implant into a tissue level implant. So that will be something like a one abutment, one time concept and zero bone loss concept. So for those who are interested, who are already placing implant, you should find out all these theory behind why we are doing all this.
Yeah, if you place a bone level implants, it's easier for you to control emergent profile of the crown of the superstructure because you can use a customized abutment. Nowadays, we always use customized abutment. Or you can contour the soft tissue by using customized healing abutment instead of standard abutment. Then your implant will have a nice emergent profile. So you can reduce the foot trap issue and the patient will be happy with it.
Yes. So because we have been placing too much emphasis on the bone, so now we should concentrate more on soft tissue. And you can see now soft tissue actually is very important in the long-term maintenance of the implant. Ian, any more? Any risk of infection by doing immediate implant placement after extractions and how to avoid infection?
Of course, there's certain criteria or certain protocol you have to follow when you do immediate implant. You never do an immediate implant in an area with a big infection or whatever. You have to follow the strict criteria of immediate implant.
Okay, so first of all, the site should not have acute infections. Number two, the chronic infection, if it is just a sinus and if you think you can manage, and then some of us actually use some local antibiotic to soak the area for about 3 to 5 minutes and then irrigate and make sure you actually curettage and remove all the granular tissue before you talk about placing implant. If it is not, then you should actually control the active infections and then bone graft, then only talk about placing implant. So the no hard and fast rule. So it's all basic physiology. So you have an active infection and you put an implant, which is a foreign body, it bounds to fail. Okay, Ian? In your experience, have you experienced difficulty of placing the final fixture despite using the correct drill and countersink? How do you overcome it?
No, again, there's a different type of bone. There's a soft bone, hard bone, and those not so hard. So if you are placing implant in a very like a type 1 bone, you have to countersink it. But do you experience? Yeah, if you really cannot put your implant in, then you just have to enlarge uh you have to enlarge your osteotomy.
Osteotomy side. Yeah.
Yeah.
Correct. Yeah. So normally for the soft bone, we might want to do a reduced size. That means one size smaller of the drilling osteotomy side. If the bone is very hard, you have to go full length. You have to countersink. Or if still cannot, you have to reverse the implant, and you might need to tap the bone before you can sit the implant. And you must know the geometry of your drill and your implant, whether your Y diameter or the length of the wide implant drill is correlate, because some drill is actually 0.5 or 0.2 by design longer than your implant, so you have to drill a bit deeper.
Yeah, correct.
Or whether your coronal flare of the implant design is bigger, then your countersink must be deep enough. If not, it will prevent the proper sitting of the implant.
Yeah, correct. If the implant, you have to use a lot of torque in order to torque in the implant, please don't forcefully torque it in. It's too dangerous. It will cause bone necrosis on the cortical bone.
Would you recommend a redo of implant if peri-implantitis occur more than once?
Or would you recommend redo peri? Normally, you have to find out why the patient has peri-implantitis. If the peri-implantitis is due to the implant is not placed properly, then of course you can repeat the implant placement. But if it's due to the patient lack of good oral hygiene, a patient is a heavy smoker, then we have to advise the patient before we redo the implant.
So would you recommend to treat the peri-implantitis, Dr. Ong?
Would you redo the implant if peri-implantitis? Oh, depend
No,
on
do
what.
you treat peri-implantitis?
Yes, depend on what type of peri-implantitis. If let's say it's a, how to say, if that you think the prognosis of the implant is still good, then we should treat the peri-implantitis before we redo the implant.
So if more than once, would you retreat or you redo the implant?
If more than one, will you retreat and redo the implant? Again, I think you have to see what's the problem, why the patient have peri-implantitis. If he is a heavy smoker, whatever, no point of redo implant, because with a bad oral hygiene, the implant will still have peri-implantitis.
So peri-implantitis is actually a very big topic, and we are still learning about peri-implantitis. Of course, there are protocols who tell you how to analyze, and I think peri-implantitis is a vast disease, either due to infection or most of it may be due to cement, or sometimes it's a heavy occlusion. So you have to find out why peri-implantitis occur, and then whether it's treatable, or if it's treatable, how are you going to treat? And it's a very advanced topic, and I don't think we should discuss here. Any more questions? So we have finished the questions, and I would like to thank Dr. KK Ong for a very, very interesting lecture with very, very nice clinical pictures. And he have shown us that before you want to learn about implant or place implant, first, your knowledge must be good enough, okay? Number one. Number two, you must attend a properly structured basic implant course. Number three is that you must do continuous learning and progress slowly. Start with those areas with good bone, low aesthetic demand. After you have placed a few, then only you want to challenge yourself and the best thing is that you have a mentor to guide you to place the first few implants. So there is no hard and fast rule. And once you have placed the implant with good bone, then only you learn about all these bone grafting procedures. Start with the simple one. Start with maybe socket preservations. Then only talk about lateral bone augmentations, vertical bone augmentations, and lateral and vertical bone augmentations. But if you do your case selection properly and you learn it in a stepwise manner, and never stop learning, I think you will do good in the implant dentistry. And Dr. Ong, as a general practitioner, has shown us that with passions and we can do and achieve what we want. So try and start slowly, learn the proper way. I think implant is not very difficult to learn, but it is difficult to do a good implant surgery. So start somewhere, be guided to do a proper implant surgery. Then we'll see more and more GP doing good implant dentistry. Any more from Dr. Ong? Dr. Ong,
Okay.
anything else you want to say?
No, I think you already.
No? So then we'll end today's sessions, and thank you, the Osstem Malaysia, for a very, very nice organizations. Okay, we'll see you next time. So the next one will be with Prof. David Niao. So please stay tuned and we'll meet again. Thank you, everyone.